Um, and the extremities is really an evolving area in the McKenzie world. But having said that, there's some big studies that have been done. There's one randomized control trial that was done with patients that had osteoarthritis of their knee that were on the waiting list for a total knee replacement, and it was done by a guy called Richard Rosedale and published in 2014. 180 patients with osteoarthritis of their knee, recruited from tertiary care centre, and they were randomised to an intervention or a control group. The intervention group, they were assessed using the McKenzie Method, and if they had a directional preference, which is really the key for classifying them into that classification of directional preference, if they had a directional preference, which means that they responded rapidly, favourably, rapidly, or unfavourably, rapidly, but that leads you to classify them favourably. If they had that kind of response, they were given the McKenzie Method. If they didn't have a directional preference, they were given the current evidence-based knee Cochrane group randomized control trial guidelines on how to manage knee osteoarthritis. And it is well established that exercise improves pain and disability in people with knee arthritis. So they were given the evidence-based, at 2014, the current evidence-based treatment. The people that responded to the McKenzie assessment were given that help instead. And then the group that were randomised to a control group were just put on the waiting list. They stayed on the waiting list, I should say. And they were assessed at 2 weeks and 3 months. And the whole exercise group, derangements and non-derangement, or I should say the directional preference group and the standard care group, when they were compared to the control group, there were significantly less pain and significantly better function, which is understandable, certainly for the evidence-based strengthening and range of movement exercises, but equally so for the McKenzie Method group. But when the two groups were compared, so you had the group that had the directional preference and the group that didn't have the directional preference, the effect sizes were even greater. And there was a really significant difference, a statistically significant difference between the response of the people that had the directional preference. They responded significantly better. So much so that the Ottawa panel, clinical practice guidelines for the management of knee osteoarthritis that was published in 2017, have included this particular trial in their systematic review and guidelines, and state that an exercise program, as an exercise program, MDT is strongly recommended for patients with knee osteoarthritis, which is a really glowing endorsement of the importance of it. And following that, there was another study that was done and published in 2018 that looked at the response to people depending on the severity of their osteoarthritis. And the really interesting thing with that was that, contrary to what clinicians might expect, more patients with severe changes had knees that responded or had a classification, a McKenzie classification of a directional preference than those with less severe grades of osteoarthritis. And that is a really, really good outcome. That's heartwarming, really, to think that even people with severe osteoarthritis, the rates that can have a directional preference and therefore can potentially be improved and improved quite rapidly and significantly is even higher than people with lesser grades of osteoarthritis. So there's, and that's us just talking about the knee. There's evidence for the shoulder as well. I might do another talk, another webinar on some evidence that's come to light about shoulder and shoulder tendinopathy, the rotator cuff problems, the rotator cuff tendinopathies, and how there's evidence to really challenge the current management of rotator cuff problems by this study that used the McKenzie method to treat shoulder problems. So even though I'd done this advanced extremities course before, I'd done it 5 years ago, in that 5 years the amount of evidence that's come to light, not surprisingly, has increased. But the other thing that's changed is that it's fair to say, I think, that as a community, the McKenzie therapists are more and more confident about using it and applying it. And as we're seeing that the rates of problems that respond really well are getting higher as well. So in summary, I'd say, first of all, hopefully you can see the McKenzie method is more than just a back exercise now. It applies equally to the extremities. Secondly, it's really important to have your back thoroughly screened, and when I say screened, I don't just mean an X-ray or an MRI, I mean actually clinically screened to see whether back treatment changes your knee, ankle, hip, elbow, shoulder pain, and can't stress that highly enough. And the third take-home message for me is that as the evidence is starting to accumulate, we're going to see, I think, the MDT approach to managing limb problems become included more and more in guidelines, because there are so many advantages to it, including the cost effectiveness of it, the way that a patient can be empowered to take on their care so that they have a responsibility, they can learn how to read their problem and alter their management on a day-to-day basis as they need to. And just the efficacy, the results, the way that you can, particularly if they're a directional preference problem, how quickly they can improve. It's really mind-blowing when you actually see it being applied. So I hope that's given you a little introduction to the McKenzie method in the extremities. It's a real thing. It's really effective. It's fantastic to see it being used. And that sounds like the phone. Thanks.